Hi, everybody. Good to see you, or not see you, but good to speak to you. You can, while I'm speaking, I'll be sharing my slides, put questions in the Q&A box, and I'll try to glance at those while I'm talking. And really looking forward to speaking to you all today about aging and addiction. So I'll share my PowerPoint. I'm Annie Kleykamp, and I'm going to be talking today broadly about aging and addiction, some prevalence data, some of my data, as well as a couple projects I have going on integrating health technology into the study of aging and addiction. A couple of those projects are listed here with funding from the University of Maryland School of Medicine, also the University of Maryland Pepper Center. And I'll talk about these studies and the design. They're both getting started or ongoing. But I wanted to begin with a brief background of my career track because it's an alternative career track that I think brings some unique experience working outside of academia with industry and with nonprofits, all at the intersection of what we'll talk about today. So I had a pretty traditional educational path, getting my master's and PhD. I started with cognitive aging, which really introduced me to the aging research field. But a lot of my research in my master's and PhD was looking at something called psychopharmacology or the impacts of drugs on the brain and behavior. And my postdoctoral research, I'm here in Baltimore, was at Hopkins in the National Institute on Drug Abuse intramural program. After that, I found myself wanting to take my research and interest in psychology and public health outside of the lab. And so my first job was actually as a medical analyst. And this is when I started diving more into the intersection with health technology and these topics. And so what I did for this company, Hayes Inc., is I wrote health technology assessment reports. So these were systematic reviews specifically focused on new or novel health technology that there was published literature on that maybe um, wasn't far enough along for payers to have a lot of data. And so they needed to know what's going on with this technology. Is it actually going to result in health outcomes that could be beneficial to the patient? And public health. And so I worked on that for a while and switched gears and actually worked as a regulatory science for a consulting firm in the DC area. And that work really brought me back to my research in addiction and psychopharmacology because they focus on helping companies that might have pharmaceuticals or other novel drugs like psychedelics, helping these companies develop applications for the FDA Center for Drug Evaluation and Research, and also another center that you might not know about called the Center for Tobacco Products. And so I learned a lot about regulation, about drug development, and the challenges there while working at Penny. And then my interest with working with the FDA sort of paralleled nice for my next position, which was actually funded through an FDA public-private partnership called Action, based at the University of Rochester. And I was recruited to help Action write systematic reviews of chronic pain or addiction related interventions, so devices or medications, and to help them convene stakeholder meetings, which would involve FDA, NIH, academia, but also advocacy organizations, industries, so say pharmaceutical or device manufacturers, and really to get everyone at the table and try to tackle topics related to research and clinical trial design. So if you're developing a treatment, what are the outcomes you should be focused on that connect with FDA's goals and as well as NIH's. And so during this time, I was quite busy. It was also COVID. I developed my own science writing, little just me, BAK and Associates, but that really capitalized on everything I've been doing with the focus on systematic reviews, helping companies develop those that are evidence-based and rigorous so that regulatory agencies or really anyone, even if it's just publishing those data, could trust them. And then I had one more before I arrived at Maryland position that really took me in another angle around healthcare and innovation, which was a medical society, a nonprofit called the American Society of Addiction Medicine. And it was here that I was helping them develop something called the ASAM criteria. These are guidelines that are used by states in the US to guide the implementation of addiction treatment. So inpatient, outpatient, all levels of care, how that treatment should take place in coverage determinations. And while I was at ASAM, I'd been publishing on aging and addiction in different ways since 2011 and kept up with my publishing when I was outside of academia. And I had to convene a group on older adults and addiction. And what I found is that there were a very limited number of people that had that expertise and also had the time to contribute, which wasn't what we found for other expert groups. And so that really motivated me to return to academia, which I've done. I'm now at the University of Maryland School of Medicine, and I'm building out my own research program or lab in addiction and aging. So I'll talk about some of that today. Before I dig in, you'll notice I use terms like addiction, substance use disorder interchangeably when I'm just talking. I just wanted to be clear that the way we tend to see addiction, although there's certainly disagreements in the field, but the way I do is addiction being this broad, treatable, chronic medical disease that involves the compulsive use and harmful consequences. Now, this is a very broad term. It could involve someone that maybe has not used a substance in many years, but they're relapsing to use. So it's this idea of a chronic relapsing disorder. And whereas a substance use disorder, the specific names of those, like tobacco use disorder, opioid use disorder, are actually specific diagnostic criteria. And so sometimes in research that I'll present, there will be a specific substance use disorder. And other times it might be people that are showing signs of substance use or misuse, as some people historically have called it. And then in addition, with age, it's a tricky thing in addiction research. I know in the US, we often define older age as 65 plus. The World Health Organization has 60 plus, but what you'll often see broadly in substance use research is a younger time frame. So often people will define this as 50 plus. And sometimes in studies as young as 25 plus, which is arguably definitely not an older adult, but I think there's a couple reasons for this. Older, we have, and you'll see some discussion on this today, a lack of representation among older adults in substance use research. And I think historically this has been a focus on prevention, which often pulls us to the younger end of the lifespan. So if I think the concept is if we can prevent it from the start, we never have to deal with it. I don't think that's a reality of addiction, but it's certainly a big component that a lot of young people are starting substance use. It's more rare, although not exceptional, for it to start later in life. But we also know that substance use, especially things like tobacco use disorder, alcohol use disorder, can really accelerate physiological aging, the aging of the brain. And so you will see that adults, say 50 and over, in a substance use treatment clinic will have a lot of multimorbidity that may be more characteristic of older populations that don't use substances. So why should we care about it? Why should I be talking about it and building my career around it? Well, one, I'll say in the addiction field, we've already been focused on particular age groups. What I'd argue most of those are young. Headlines often focus on this. You often hear the term crisis with youth and substance use. And there's good reason for that. Certainly, there's a lot of harms. You've got the developing brain, and there's ideas of if you start substance use early, will that lead to other substance use later? But the truth is, substance use has decreased a lot and is quite low among young people, sort of historically low. So here are the monitoring the future data that we collect in the US for many decades now. In here, you have tobacco smoking from 1976 to 22, lowest levels ever recorded for youth. Alcohol use is really down any scheduled drug use trending down. Even novel things like e-cigarettes, which I will talk about today in a very different context from youth, those are dropping to low use. So we have really promising patterns. Maybe this is demonstrating that emphasizing this focus on young people is really resulting in public health gains. But things appear to be very different for older adults. And so I'll just quickly go over some of those patterns. In terms of harm, we know that deaths, for example, from alcohol are much more common among adults 55 to 74, given the toll of alcohol across the lifespan. As well as Maryland, we have the highest opioid overdose death rate in the country, but these deaths are most pronounced among adults 55 and above. It's been something that was covered by the New York Times and our Baltimore Banner. So a lot of people, which is good news for older adults, are focusing on this population in Baltimore and opioid overdose. But you also see this with smoking, which is something I study. Although most people start smoking in their teens and early 20s, the death and disease really come on later. And so here you're seeing in the lighter orange how the most of the people dying, or nearly half, are 70 and above, and you've got your 50 to 69-year-olds from smoking related disease. In terms of prevalence, so SAMHSA released a report. They've got a couple valuable reports on older adults and substance use if you haven't seen them. This one suggesting, about 12% of older adults defined as 60 and above report past month smoking, past, about 13% binge alcohol use, and then lower heavy alcohol use, but still significant. Less frequent use of things like illicit drugs, so fentanyl, an opioid, but you do have considerable past year use. So it's not negligible, which I've been told before, because historically substance use patterns have been much lower for older adults, but we're seeing changes for that as sort of prevalence converges, especially in something like smoking tobacco. So these are data that I'm working on with some colleagues from the Health and Retirement Study. So what these are breaking down are risky drinking. I've got the drinking outside of guidelines definition here. But what we're finding, looking across different waves of the HRS, is that risky drinking is significantly increasing across many demographics. And you see how this risky drinking prevalence is quite similar to between people between 50 to 84 years old. But we do see different patterns. We looked at this data set with drinking, smoking, and co-use. And what we found is that this risky drinking is more common among people living above the federal poverty line, so the red lines. You're seeing more of this alcohol-related harm, although there does seem to be convergence over time between these economic groups for risky drinking, but you have the opposite for tobacco smoking, where you see, people that live above the federal poverty line much less likely to smoke. You also see this with education status. So it seems that with our risky drinking patterns and some concerns with older adults and this prevalence increasing, it's often more among people that might be economically stable, highly educated, and white. Whereas with smoking, this often is people of low socioeconomic status, and more likely among older adults identify as Black or African American. So different patterns, so the intersectionality within age. I also mentioned smoking prevalence. Something we don't talk a lot about is because we're really doing great in reducing smoking among young people, this blue line, even lower for high school and middle school. This purple line are older adults. So we're not seeing smoking prevalence change for this older age group, 65 plus. And for the first time ever since we've been recording these data since 1964, older adults are more likely to smoke in nearly every state in the US. And also some data also based on the NHIS, smoking prevalence has increased for older adults living below the federal poverty line. So this is sort of getting at that economic disparities that I was showing on the previous slide. And it's really shocking actually to see smoking prevalence increases. You don't see that anymore. If anything, you're seeing a lot of decreases. And so I think this is a segment of the population that has a high treatment need. The other part of smoking you'll hear me mention a lot is often goes alongside other substance use. So we call that polysubstance use. So it could be someone smokes, but they are also drinking, or maybe they're smoking tobacco, using cannabis, and drinking. So the interesting thing is, even if something like smoking, it's not uh, increasing significantly, but if it is, it's for certain subgroups, but it's staying the same. But if you take these numbers and use US Census numbers, what you estimate is just about 10 years ago, maybe a little more, we had significantly more young people, 18 to 24, smoking than older. But that's significantly reduced because of these drops in smoking. But at the same time, because smoking prevalence isn't changing for older groups, you're getting an increase in the absolute number of people who smoke, which is greater burdens on the healthcare system. And of course, a greater number of people living with smoking related disease later in life, which can really contribute to reduced mobility, a lot of disease states, as you might imagine, not only early death, but reduced quality of life. So those data sort of paint the picture. We've got different trends. I could go into cannabis use, which has been increasing for older adults as well as other substances. But what about treatment? So in the SAMHSA report, they estimate getting up to 9 million older adults need substance use treatment in the US. However, they estimate only 1 in 3 receive it. This is for a variety of reasons. There's a lot of stigma with any type of addictive disorder. And so a lot of people may not seek treatment. Inherent in the disorder is that you're taking in drugs that you may not want to stop using because you may be in a pattern of use. They may help you escape from things in life so that the idea of stopping their use may reduce your seeking healthcare. But it's also the case that the healthcare system might not be, developed enough to deal with older adults with addiction. So you're getting some more data with first-time treatment admissions for alcohol use disorder increasing over time. These data on the right are a little older, but also showing the purple line, opioids, as well as cannabis or marijuana. You're seeing at least about 10 years ago, an uptick in stimulants as well as benzodiazepine, people seeking treatment. But Hune et al. Estimate that fewer than 25% of addiction treatment facilities offer specialty services for older adults. I think I saw a recent publication where this has increased, which is, a great news. But I think that there's a lot of workforce development to get there. So, another element that I should touch on, so you've got these patterns of use, you've got patterns of that differ from young people, you've got potentially increased harm of substances, or at least unique harms because an aging adult already is experiencing, age-related changes that could put them at risk for substance use harms. But also despite these calls for research, NIH, national academies, there was a US Senate committee report released in late 2023 that, was trying to get at this opioid overdose disparities with older adults dying more often. They report we need more research, is basically what they said. And this has bared out in systematic analyses of the published literature that Rosen and colleagues have done, as well as myself more recently on tobacco research. So we both found that about probably a little less than 1% of articles in leading journals examined older adults and substance use. So there's just a lack of research looking at the intersection of those topics. And I also found in my study, in tobacco research, so I looked at the leading worldwide society on tobacco research, SRNT, and its companion journal. And we analyzed what's been presented from 2019 to 2023 there or published. And we found that over 70% of the things presented or published, or of the abstracts, they focused exclusively on youth and young adults. So, like I mentioned, there is a disproportionate focus, I think, on youth with an absence of research on older adults. And reasons for this we could talk about, stigma related to addiction, also age-related biases. But I wanted to share some feedback I got. I submitted a viewpoint article to JAMA earlier this year, and I was happy that it even got reviewed. It got reviewed by one reviewer. It did get rejected, but the comment from the reviewer that rejected it, I think, highlights some of the things that I hear when I'm presenting on this. And I'll read it to you. So they were not in agreement with me that older adults are a very important segment of the smoking population. That's what my paper is focused on, tobacco use, in part because it's more difficult to change older adults' behaviors and because they know very well that they should quit. So there is little information that would be new to them. I couldn't disagree more with this reviewer. I think that one, the underlying statement is really ignoring what we understand about substance use and addiction, and honestly, any type of behavior, because we may know very well we should work out more or eat less or not use opioids or smoke tobacco. But if you're using a substance that intersects with the brain in a way that is impacting the reinforcement system, you may know you need to quit. But there's tools, very refined tools that we use in addiction to help people quit in that context. So that was unhelpful. But I also think this idea it's more difficult to change older adults' behaviors. I hear that. And the lack of information that would be new to them. I think there'd be a lot of information that could be new to them, especially if we started doing research involving them and also asking them, because we don't even know a lot of these characteristics. And so I view this as a quit or die approach to aging and addiction, which could apply to other treatments if we said, I don't think older adults with cardiovascular disease are a very important segment of the population. I think it's important that we understand that there are things we can do, and there's many interventions we've developed, yes, focused on younger middle-aged populations that I think that older adults might not be aware of. And so I think it's unacceptable to view it this way, but it is a barrier. So, innovation in technology. I'm going to just talk a little bit about what a lot of other people have summarized. I tried to list these different reviews, commentaries. A lot of people are talking about what I'm talking about now. But the idea that you already have things in aging like multimorbidity, but then with addictive substances or substance use disorders, you can really get intersecting variables. So you get maybe someone that already has existing chronic pain using an opioid, but they have a history of opioid use disorder. Or you could have someone that's drinking a lot, develops comorbidities with that, cardiovascular disease, but might also have other age-related changes in sleep that intersect. So we have this element of multimorbidity with aging and addiction. Mental health, of course, we know that things like depression as well as serious mental illness significantly correlate with risk of addiction. And we also know older adults might be facing things or navigating, especially in the context of substance use, grief. And so, for example, I work with my research at an outpatient opioid treatment clinic in West Baltimore. Most of our patients are older, are 50 years and older, so 75%. And I talk with them. I am currently enrolling them in a study. I've met with a patient advisory board, and they talk a lot about the number of people they've lost to overdose. And it's a very unique type of grief. And these are friends, these are acquaintances. And it's really profound how many people they've lost to that, which is a unique aspect of grief and substance use. We also know that social isolation and the stigma that comes with substance use can be really profound for older adults, also mentioned by our advisory board of people with lived experience who were older, that social isolation really was related to their substance use and lack of treatment engagement. Function, something we don't measure a lot as substance use researchers, is things like mobility or cognitive functioning. Often we're just focused on whether the person is or isn't using substances, or maybe whether or not they're having withdrawal from the substances. But there are these other really impactful quality of life outcomes I think that we need. Of course, you've got, as I mentioned, with substance use, some types intersecting with lower income status, like tobacco use. Also differences in insurance coverage or lack of it, and then ability to provide different types of addiction treatment. Um, Goes without saying to mention the physiological changes with aging. I'm really interested in metabolism and how using substances like tobacco alters metabolism, which then can alter the metabolism of prescribed medications, but also involved in that you have aging related changes in metabolism. And the two things I'll talk about in a little more depth on the next couple slides are polypharmacy and what I see with its relationship with something called, I've mentioned, polysubstance use, and then harm reduction in the context of addiction. So I don't think these data will be surprising. These are just showing with the top line, adults 65 and over, and the middle panel here taking three or more drugs, but you're seeing prescription drug use much higher among older adults. You're also seeing five or more drugs, much higher for older adults. You're seeing these trends, an upward trend, so increasing polypharmacy, at least according to these data. But one thing we don't talk about is the idea that someone might have polysubstance use, polyprescription use concerns, but also might be using multiple substances that are recreational, so not prescribed at the same time. So alcohol, tobacco, and these are all intersecting. And like I was mentioning with metabolism, and this comes into play too with a joint clinical practice guideline I helped with through the American Society of Addiction Medicine on benzodiazepine tapering. This is published recently. And I did the systematic review for this. And what we found was very little research that we needed more research actually on looking at tapering of benzodiazepines. But what happens in the context of someone that's already, say, has an alcohol use disorder, and they also are showing signs of needing to be tapered from benzodiazepines, and if they're older, which is likely with those things. Um, let's see. So I'm just looking at the comments really quick. Yeah, so similar type of reaction. Oh, Adam Green, thank you for your comment. So in terms of the quote I got from the reviewer, similar type of reaction to a recent submission that they made. How do we overcome this aspect of getting funding? I have some ideas at the end of the presentation. I'm really open. And also, if anyone wants to reach out after this, I do think that speaking like this and sort of increasing our collaborations in the aging and addiction world, we can get some more things going. Maybe being able to have our own small conference on aging and addiction and getting more attention, writing commentaries, even editorials in the popular press. I think that there's a couple barriers to overcome when you're talking about aging and addiction. There's the first barrier of aging, with a lot of research has overlooked this age group. And then you have the stigma of addiction and the idea that it's a moral failing and a choice. And then Phil asked, can you comment on the notion that because GLP-1 drugs attenuate the reward behavior complex, it's possible to treat addiction in older adults that may be resistant to change? Um, yeah, so exactly. So I'm not part of these trials, but we do have two GLP-1 drug trials at the outpatient opioid treatment clinic in West Baltimore ongoing. A lot of the patients in those studies will be 50 years and above just because of the census. I think there's great potential for that. I've seen some of the data. Actually, I've also seen some potential data with GLP-1 drugs and tobacco smoking. And so I think that looking at novel treatments like that, as well as psychedelics and things that might actually alter behavior in different ways than, say, methadone, which is the most common treatment at the opioid treatment clinic, an agonist. Okay, so I'll go on and I'll try to catch these questions, but I'll move forward a little. Let's see. Okay. So harm reduction, I'm just going to talk about because this is a key element of my research with aging and addiction. And so harm reduction, I think we're all familiar with it in these more traditional terms. Like it's the idea that we're going to minimize the risks of a behavior, like going out in the sun, while accepting that we're not going to require the person to completely stop a behavior. So this is similar to, say, demanding someone abstain from all drugs, or in tobacco world we call it cessation, but saying, okay, if that's not what you want, or you have been unable to achieve that despite wanting it, are there other ways we can reduce this harm? We do this in a lot of ways. You want to play football, we've got football helmets, condoms, and also with respect to drugs, have with syringe services. So this would be for someone who may be injecting drugs. And so providing them with clean syringes reduces the risk of infectious disease. And so, on that note, someone named Ben Han, who's a really a leader in this field of aging and addiction, published a paper that caught my eye a few years ago on the integration of harm reduction in geriatric medicine. And I think he really connected it in a way that made sense to me as an addiction researcher that's focused a lot on harm reduction outside of age. But he talks about how both geriatric medicine and harm reduction approaches frame care in this complex competing risks. Also, what are the patient relevant benefits? What is the patient, wanting for their life? And it's removing an absolute focus on curing or fixing it. And I think this is important because you do have, according to national survey data, for example, a lot of older adults, nearly half, about 50%, who report currently smoking say they do not want to quit. You also have older adults who are the least likely to make a smoking quit attempt. And so what you have is maybe people that might not want to seek a fix completely, may still want nicotine, but want to get there through a reduced harm approach, which I'll talk about. So I'm just going to talk about a couple pilot studies that I have ongoing. This one is older adults who smoke tobacco and something called an e-cigarette, which you've probably heard of, which is somewhat controversial. I'm treating it as a harm reduction tool, and I'll explain why. The site of my study is actually the outpatient treatment center I mentioned to you. And so, I've mentioned that you have these opioid overdose deaths higher among older adults, especially in Baltimore among Black males. And so our clinic's sort of in the hub of that. So we're reaching a lot of these people that could be negatively impacted by an overdose. Here's the treatment clinic on West Pratt Street. And like I mentioned, about 75% of our patient census, and it ranges between 300 or 400 any day, are 50 and older. So why study smoking in this context? Well, we know that smoking prevalence is significantly higher among people with substance use disorder. So you see about 75%, according to some of these publications, of people smoke who have a diagnosed substance use disorder compared to 12% in the general population. And it's estimated that nearly half of people who smoke but also have a substance use disorder die of smoking related disease. So this is more than the general population. So it's a significant harm. And we also know that treatments like the nicotine patch, the nicotine gum, a drug called Chantix, have lower efficacy in controlled trials and effectiveness as well. Only 1 out of 10 people, it's estimated, quit smoking if they have a co-occurring substance use disorder with these medications, compared to 1 out of 4, about 25% of people quit smoking with these interventions. We also have this element of innovation where we've had no new FDA approved smoking cessation interventions for close to 20 years. Chantix, or also called varenicline, was approved in 2006. So that's really not a lot of innovation in terms of drug development, although e-cigarettes have come on the market since then. And something to keep in mind is that there's a lot of data out there, population level data, just suggests that reducing smoking, not just that complete quitting or the complete fix, even late in life, so 60s, 70s into 80s, can increase life expectancy. And I think more importantly, improve respiratory health and some of these outcomes that might improve quality of life. Okay, so why e-cigarettes? So I'm going to do a brief 101 on these and harm reduction related to tobacco, just to give you a snapshot of my views of these products. And I will say, no nicotine products completely safe, even nicotine replacement therapy that actually you can buy on the shelf without it being locked up at Target now, because it's very low likelihood of being abused by anyone, including youth. But we don't want people initiating an addictive substance that they might have trouble quitting or could have harms to them. So I just want to be clear, it's not that I'm saying we should be promoting use of e-cigarettes. But among people who smoke, these are important facts. So we know that smoked tobacco cigarettes, the traditional one that's still for sale at all the Royal Farms in Baltimore, retail sale throughout the country, it's the most deadly consumer product in history. And we've gained in the US more and more control over the regulation of this product since the passing in 2001 of the Tobacco Control Act. And what that established was the FDA Center for Tobacco Products. Unfortunately, despite the establishment of that, because of the history of tobacco cigarettes, they remain on the market. But we know that nicotine, when it's pulled away from all the smoked and combustible tobacco components, is not a direct cause of cancer or respiratory disease. This is actually a misconception that a lot of physicians have too, also the public. And this is more debated, but it's considered much less likely to cause heart disease. And again, this is a comparison between nicotine, just pulling it away from tobacco products, versus a smoked cigarette. And I worked with the American Society for Addiction Medicine on this. I wrote one of their chapters in their criteria with an expert group. And we included this graphic to reflect the relative harm, which is inherent for educating people on tobacco harm reduction. And what ASAM endorsed, and this is based on a published study of expert consensus on tobacco harms, you'll see that smokeless tobacco are considered far less harmful than combusted and the cigarette, including e-cigarettes. So we know this now. E-cigarettes came to the market around 2006 to the US. They deliver nicotine without smoke. They are not completely safe, but considered safer than smoking by the FDA if you were to completely switch to them from smoking. And the FDA has authorized some e-cigarette products, meaning that they have deemed them for the protection of public health because they have reduced risk compared to smoking. And really, the mechanism FDA is doing that through is the power they were given through the Tobacco Control Act. And what that does is help put products on the market that are not combustible like cigarettes and ideally less harmful. And in addition, and what prompted me to choose e-cigarettes is that there's been a systematic review, a Cochrane review, of now, I think about 30,000 patients, multiple studies, and it's found that e-cigarettes are more efficacious than nicotine replacement therapy for quitting smoking. So now we're seeing that a consumer product, the e-cigarette, which by the way was developed by a man named Han Lick in China in the early 2000s, unaffiliated with industry, but it's now gotten completely tied up with the tobacco industry. So there's complications there. But if you're seeing this being more effective than nicotine replacement therapy, the idea is that there are people that don't want to use FDA approved medications, could they use this e-cigarette as a harm reduction tool? And that's what I'm looking at. Sorry, this slide says estimated start date with August 2024. That happened. We are nearing our 30th participant. Just to give you a sense of eligibility, these are people 50 and older in the outpatient opioid treatment. Most are on methadone for at least 3 months. They currently smoke tobacco. Most have smoked for 40 to 50 years. They don't use e-cigarettes regularly and they don't want cessation treatment. So they're not interested in medications or provider advice, which we could connect them to. They come in for 4 separate visits. We follow them through 8 weeks, and we basically do one of 2 things. They're randomized to standard care. So this is usually what a person would encounter going in an outpatient treatment clinic around smoking. They're given brief advice to quit smoking by their counselor who does the intake. They're also connected to a 1-800-QUIT line that Maryland sponsors that can provide free nicotine replacement therapy and counseling. And they're ideally, this is a little extra than what we do at the clinic. You know, you ask, advise, assist, assess, assist, and arrange. Basically, just sort of like helping that person, if they want to quit smoking, get the resources they needed. And we have a packet of resources that we share. So that's half our participants randomized. The other half do get this FDA authorized e-cigarette. It's called an Enjoy. It's available for purchase next to regular cigarettes that the participants are smoking. Nearly all of our participants smoke Newports, which are sold at Royal Farms, all types of places around here. And so what we do is educate the participant on tobacco harm reduction. They see the figure that I just showed you and some facts about nicotine. And then they were just asked to use as little or as much of e-cigarettes as preferred. There was no control over that. And they took it home and they told us, and it was a pilot study. And we just submitted data. Unfortunately, I didn't include them here because they're very preliminary, but we are seeing significant reductions in carbon monoxide exposure in the e-cigarette group versus the standard care group, which suggests switching. And the numbers add up to that. So people in the e-cigarette group are reducing their number of cigarettes smoked compared to standard care. But those data are preliminary, and so hopefully we'll have some final data to publish in a month or two. So the other study, I see I'm coming up on 40 minutes, so I'll try to get through this. And I know we've got some other questions. So let me just describe this study and I'll return to questions. So this is a newer one. I got funded through the University of Maryland Pepper Center, and I've got lots of mentors. It's really, as a substance use researcher, connecting me with aging expertise that's really going to be critical for helping me do quality work with older adults. And what I'm really interested in are, again, the older adults in outpatient opioid treatment, but at a different angle this time, not tobacco use, but instead cognition. And this is something I studied a lot in my graduate and postdoc training, the cognitive effects of drugs. I also did cognitive training research with older adults with mild cognitive impairment. That was my master's work. And so what I wanted to extend was some of that work, but using some novel technology. So we know that cognitive functioning is impaired among people with opioid use disorder for a variety of reasons. There's a higher history of head trauma. You also have a long history of substance use. We also know that opioid overdoses contribute to cognitive decrements. They might be lasting. And lower levels of education among people with opioid use disorder, at least in certain settings. And what you'll see a lot in the reviews on this literature, which I tried to cite a couple, are executive functioning and working memory are often the focus. So in studies looking at functioning, less importance put on episodic memory or long-term memory, because really what your challenges are you're seeing are being able to, inhibit information as well as manipulate it in the short term, which can impact treatment. So there are some studies that looked at cognitive training, so incrementally more difficult cognitive task administration over time to sort of exercise the brain in hopes that could transfer to other cognitive tasks and to treatment. And there have been signs of improved cognitive function even on tasks that weren't associated with the training, increased time in treatment, so in outpatient treatment for opioid use disorder, as well as reduced substance use. So, for example, less illicit use of something like fentanyl or cocaine. So that's been correlated with cognitive training in some of these lab-based studies. But there are very few that focus on patients with opioid use disorder. I'd say a lot focus on alcohol use disorder. And the two that I have cited here, one I helped start, although I'm not an author on it, and that was in my lab at Hopkins with Miriam Mincer, who did a lot of this early work. None of this research includes adults 55 and over. And historically, as I did with my research as well as others, these studies have been in person and very time intensive. So, for example, 2 hours of baseline cognitive testing, repeated cognitive training sessions in person. Sometimes those are lasting, 30 minutes or longer. And it can be quite a burden on patients, limit real world insights. And I also think a challenge for older adults because in outpatient opioid treatment, you can get take-home medication, which often happens for older adults who are adhering to, the expectations of their treatment, and they may have mobility issues. So my study is a very small feasibility trial of remote cognitive testing and training using these gamified smartphone-based tasks through a company called NeuroUX. Tasks on the smartphone take a total of 15 minutes a day. I have them split between morning and evening because you do have different impacts of methadone dosing, which usually happens in the morning on cognition. And so you can look at the peak and trough effects. And so they'll come in for a baseline session really to get their baseline functioning, including trails making tasks, the MOCA for their cognitive functioning, their substance use history. They'll do 5 days daily, twice a day of just testing where the cognitive tasks remain the same perform or difficulty. And then we're going to attempt to look at remediation or training. This is a very brief timeline for that. So I'm not sure what we'll find, but I'm very curious if our older adults will engage with the task, how often they will, and what they'll think of them. And we'll get feedback on that. Of course, this is for a larger trial to see what's possible. We'll also do a qualitative interview portion. We'll interview patients and providers at the clinic to understand not just cognition and opioid use disorder, but the aging component. Okay, so I'm going to pause there really quick and see what else we have. Um, yeah, so we have a question. What do you think about Delta 8 THC or THC related stuff? I've seen older people are using these substances for pain and other reasons. Yeah, so I've encountered this personally with my mother who has chronic pain. She does not take opioids, but she also has a history of falling and a lot of respiratory issues. And she lives in Kentucky, taking, and I don't do research. I'm part of one study that looked at the epidemiology of cannabis use among older adults. So don't have as much expertise there, which is definitely a gap for me because I think cannabis use is increasing. You have these forms like Delta 8, which is a different form that in some states you can buy, which is sort of different regulations around. I think with the increased access with recreational use, I think it's really something to consider, especially if older adults are combining, THC products with other drugs they might be taking, as well as this risk of falls or dizziness. It's something I really was concerned about my mom about. And I haven't given her specific guidance because I don't feel highly educated on the interactions, but I do think it's one of those topics that of real high importance, especially in a state like Maryland where medical and recreational are here, and I imagine increasing access among older adults. Yes, and someone highlighted the 2022 Medicare coverage includes OUD treatment services. That's true. So we're getting, improvements in coverage for older adults. An interesting thing with Medicare is how it doesn't cover all smoking cessation treatments. So it actually doesn't cover out like over the counter nicotine replacement treatment, like the gum patch or lozenge. I think that's a huge gap because the out-of-pocket cost for those can be high, and you can get them free through 1-800 numbers like our Quit line in Maryland, but I find that a lot of patients don't use that. And then how do we get involved in trials? Um, so maybe Dr. Faison, you can definitely reach out to me about the research we have going on or other ways to collaborate. I am very much, as an early career investigator, looking for ways to collaborate. So very much, if you could reach out to me. Currently, I have these trials ongoing. I have some other R grants submitted. But as you all know, in the current funding atmosphere, I think, as you'll see on my next few slides, the more we can collaborate, the better. So I just wanted to highlight the obvious. So, we have aging research, which a lot of you are producing, which is really important. You have my area of expertise that intersects somewhat with aging. I would say less so probably than health tech. And then you do get some overlap between health tech research and addiction research, a lot to do there. But in terms of drug development, new devices for administering drugs, measurement. But that intersection where these three come together, I really think, given the prevalence estimates I've shown you all, the increase in substance use, the unique different subpopulations and how it impacts people maybe that be higher socioeconomic status differently from lower, it's untapped potential for, of course, research, which I think is lacking, treatment in terms of healthcare capacity and coverage, but also the innovation that both of those need. And so I just wanted to leave with, and I'll open it back up for questions and comments, just some broad picture thinking. I was very excited to get asked to do this talk because, as you saw, I have a diverse background, and I'm really interested in the importance of how do we think out of the box on these things using, innovation and also business models, and how do we do this as quick as possible, given the growing older adult population and the ongoing impacts of substance use. But I'll start with pragmatism and what I think in terms of how we think about, say, addiction or aging needs to change. So, as an addiction researcher, someone that's been studying this for 20 years, and as someone that got into this field because my father was struggling with opioid use disorder from the day I was born. He went to inpatient treatment at age 5 when I was 5. And so I've navigated this. And the way I see it, studying addiction, is humans are wired to seek addictive substances just because the way our brain is wired with reward and reinforcement. So I think that there will always be a demand. The idea that you can remove addiction as a health condition, just like we can't remove cancer completely, although we try to reduce and eliminate. So we need to think about addiction the same way. Addiction is a chronic health condition with profound individual and societal costs across the lifespan. So this is not the way we often think of it in the addiction field. And I think people either overtly exclude older adults from research or they're just not part of the conversation, including policy and funding decisions. We also know that the fastest growing demographic. So when you have increasing signs of substance use in this population, that combines with that growth in important ways that should be capturing our attention and resources. So as an addiction researcher, what I'm trying to do is reach out and connect more with aging researchers or people maybe that are already in the addiction field and have some expertise in aging or vice versa. I think a lot of this is currently siloed, and we have a lot of work to do to combine, expertise. As my past work with a FDA public-private partnership emphasizes, I think that in addition to, collaborating, say, across academia, I really want to see more of this cross-sector collaboration that we've done before for other topics like chronic pain and addiction broadly. And I also think prioritizing, sorry, I think I've talked too much, so I'll go fast. My throat's starting to get dry. But prioritizing input from older adults with current and past addiction, which we're doing at our treatment clinic. And finally, disrupting the groupthink. So I think that thinking of addiction as just a young person's problem is prevalent, and we can't always prevent addiction. So despite our best efforts, people will use substances later in life that are addictive. I don't think abstinence or cessation are the only answer. And I think this is really critical for innovation because if you broaden that to not just include a drug that completely stops use or an innovation or device, but interventions that along the continuum of use can reduce the harm, you really broaden what we can develop. And then I think outcomes beyond substance use, especially in older populations, truly matter and are underassessed or not at all. So mobility, frailty, cognition, social interaction, and quality of life. Okay, so thank you. I'm just going to quickly show my email. So someone in the audience is working on overdose in older adults. Oh, great. Using the All of Us data set. Yes, would love. I went to an All of Us um, sort of webinar to learn more about their data. I'm really interested in it. Would love to talk more. Um, Feel free to email me or hopefully my information shared. And one thing I'm interested in is the risk of this overdose among older adults that are already have a respiratory compromise, which would make sense. And so the higher chance of death from opioid overdose, what does that look like when you break it down if they already have a comorbid health condition like COPD? Very interesting. And then here's another comment, the NIH Med Tech Blueprint Program. has health tech as a priority. Great. Thank you for sharing that. So, for anyone else learning this like me, NIH MedTech Blueprint. Um, Great. Yeah. So, yeah, if you're new to aging and addiction, I'm there with you. Although I've been thinking about it a long time, I'm just getting started and trying to get the funding to make this possible. Um, would love to hear more from you. And then, oh, yes. So let me I wonder if I can here. Okay, great. Type answer. I'm going to put my email here in the chat if anyone wants to, and also my name, because you will see it as Bethea Kleykamp. But I also go by Annie. You're welcome to call me. Bethea is my in the email. So hopefully everybody was able to get that. Um, and I think we're getting close to time. Any other comments or anything you want to add, Anne?
Thank you so much for doing this for us today. Take care and have a good day.